and welcome everybody to this webinar on the 4th edition of the Bayley Scales of Infant and Toddler Development. And today our focus is going to be on the screening test. Some of you may know that we published the Bayley-4 in September, and we were thrilled to begin shipping those, and we hope that some of you have received the ones that you ordered, and we hope that you will be just as excited to receive the Bayley-4 Screening Test, which we anticipate shipping in November 2019, which is right around the corner. Before we begin with the actual content of our presentation today, and before I tell you what we will focus on, I want to see how many of you are familiar with the Bayley-3 screening test. So if you would please answer this question for me. Have you used the Bayley-3 screening test? Yes or no? And then click Submit. That'll give us an idea of your level of knowledge related to the content for our webinar today. And it looks like the majority are not familiar with the Bayley-3 screening test. It looks like we do have a large number of people who are. You'll find as I describe the content of the Bayley-4 screening test that there will be some similarities between the Bayley-3 screening test and the Bayley-4 screening test. And if you've attended any of our webinars on the Bayley-4, you'll also notice that the Bayley-4 screening test will mirror the changes from the Bayley-3 to the Bayley-4. So the changes that were incorporated in the Bayley-4 will be translated or transmitted to the Bayley-4 screening test as well. So thank you very much for your responses. In terms of the content on which we want to focus today, we want to spend a few minutes talking about the features of the Bayley-4 screening test. We want to talk about the changes in the administration and scoring. And because this is a screening test, we want to spend a few minutes talking about the technical properties. Whenever we focus on any standardized test, it's really important for us to know, especially the accuracy with which the test predicts whatever the construct of interest is, or predicts performance on the construct of interest. When you're thinking about a screening test, it's especially important because effectively what we're trying to ascertain is the extent to which the screening test will allow us to identify individuals, in our case for the Bayley, to identify young children who are in need of a comprehensive diagnostic evaluation. So we'll spend a few minutes toward the end talking about the technical properties. And then we'll conclude by looking at the comparisons between the Bayley-4 screening test and the Bayley-4. So to get us started, I want to just provide a brief overview of the Bayley-4 screening test. This is going to be a shorter version of the Bayley-4. It will allow us to quickly determine if a child is on track developmentally or if we need to refer for a comprehensive diagnostic evaluation. Just like the Bayley-4 and like the Bayley-3 and the Bayley-3 screening test, the test will be used for infants beginning at 16 days and going up through 42 months. We've already described that it's going to be published in November. Qualification level for purchasing of the Bayley-4 screening test, just like it is for the Bayley-4, is level B. This one can be completed in approximately 15 to 25 minutes, and the administration is going to be paper and pencil. Those of you who've attended some of our webinars on the Bayley-4, the paper and pencil option, as well as an on-screen option available through Pearson's Q Global platform. In terms of the scoring and the interpretation, for the Bayley-4 screening test, we will provide cut scores by age like we did for the Bayley-3 screening test. And the scoring option, just like the administration option, is going to be manual. The tables for the cut scores will be provided in the manual. In terms of the content, you'll notice that the content is consistent with the content for the Bayley-3 screening test. We focus on 5 subtests cognitive, receptive communication, expressive communication, fine motor, and gross motor. The Bayley-3 as well as the Bayley-4, as you know, includes certainly these 5 subtests, which cover 3 different scales: cognitive, language, and motor. And the Bayley-4 or the Bayley-3 both will actually, in addition to the cognitive, language, and motor scales, also include the social, emotional, and adaptive behavior scales. But the screening tests will cover the 3 scales: cognitive, language, and motor, the 5 subtests that comprise those 3 scales. In terms of the content of each, the cognitive subtest consists of 30 items, and effectively you'll think about the cognitive skills that you'd expect children to demonstrate or to be developing beginning at the age of 16 days and going up through 42 months, 15 days. So you're thinking about sensory motor development, how children explore and manipulate objects in their environments, how they see the relationship between objects, for example, banging a spoon in a cup, for example, thinking about different concepts. You're thinking about the concept of color, for example, memory. Are you able to learn and remember information that you hear, information that you see? Then also thinking about some items that focus on attention and other cognitive processing aspects. So if you've seen the Bayley-4, the cognitive subtest on the Bayley-4 includes 81 items, and the 30 items on the Bayley-4 screening test are a subset of the items from the Bayley-4. In terms of the receptive communication subtest, 22 items compared to 42 items on the Bayley-4 receptive communication subtest. These items will measure understanding of certainly nonverbal communication, but we also look at vocabulary development related to objects and pictures, vocabulary related to morphological development. You're thinking about the child's understanding of pronouns, preposition, also looking at the child's understanding of morphological markers, for example, tense, the ED, the ING, the possessive S. In expressive communication, in terms of the development of expressive communication, you see the same developmental trajectory certainly in the expressive communication subtest compared to receptive communication. This one consists of 23 items that measure certainly pre-verbal communication. You think about babbling and cooing, gesturing, joint referencing, turn-taking, also vocabulary development. For expressive, we expect the child to be able to name objects. For receptive, we expect the child to be able to identify objects, certainly also looking at syntactic and morphological development, just like we do for receptive communication. And then for the fine motor subtest, this one consists of 27 items, and we're looking at the child's skills associated with prehension, gripping, looking at whether or not the thumb is opposing the other fingers, certainly perceptual motor integration, motor planning, motor speed. Is the child tracking objects visually? Objects maybe present visual tracking in the horizontal plane, visual tracking in the vertical plane. Is the child reaching for objects and being able to grasp the object, then manipulating the object? And then what about some functional hand skills where they're actually using their hands to grasp objects, maybe to feed themselves, and so on. And then gross motor consists of 27 items. And again, you think about gross motor development starting with infancy and progressing up through toddlerhood, the stability and movement of limbs and torso. You're thinking about static positioning as well as dynamic movement. Is the child able to run? Is the child able to coordinate motor movements, to jump maybe from the bottom step? What about balancing and motor planning? Those gross motor skills that you'd expect a child to develop and to be able to demonstrate by the time he or she is about 3.5 years old. So in terms of the number of items, you'll notice here that the number of items will differ, and I want to focus on the number of items for the Bayley-4 Screening Test, and I want to compare that number to both the Bayley-3 Screening Test as well as the Bayley-4. And I made some references before to the number of items on Bayley-4, but you'll notice compared to the Bayley-3 Screening Test that there are approximately the same number of items, 30 for cognitive on Bayley-4 Screening Test compared to 33 on Bayley-3 Screening Test, 22 for Receptive Communication on Bayley-4 compared to 24. So in terms of the total number of items, 129 on Bayley-4 Screening Test compared to 136 on the Bayley-3 Screening Test, and compared to 264 certainly on the diagnostic assessment, the Bayley-4. So because of the reduction in the number of items, certainly that is what influences the administration time, which means that we should be able to complete the administration in approximately 15 to 25 minutes, depending on the age of the child, and also depending, of course, on the developmental level of the child. So I want to spend just a few minutes thinking about what has changed when we think about the Bayley-3 Screening Test and now the Bayley-4 Screening Test. Well, one of the major changes is in terms of the administration of the items on these 5 subtests. So this is a standardized test, so you will have standardized instructions for presenting these items. But one of the things that has changed is that when we look at the administration of the items, we're using 3 interrelated elements. And these 3 interrelated elements will include or may include the administration of structured test items, so reading the instructions for presenting the item and then following those instructions as you're interacting with the child. But we also recognize the importance of observing directly the child's behaviors and milestones. One of the things that we know when working with infants and toddlers is that as much as we'd like it to be different, the reality is that infants and toddlers do not always respond on command, right? So when we ask them to do something, they may not necessarily do it right at that moment, but they may do it later. They may do it later spontaneously. So in addition to the administration of the structured test item, we also have a component where we can directly observe the behaviors and milestones. Now, this is something that we did on the Bayley-3 screening test as well, right? When we think about the concept of incidental observation, we described in the Bayley-3 manual and the Bayley-3 screening test manual, if you observe the child demonstrating a certain behavior at any point during testing, then go ahead and score the item that assesses that behavior. So the incidental observation is consistent with what we've done in the past, and you'll see that recognition described in some of the actual items. If you do not observe this behavior incidentally, then go ahead and present the item this way. Now, the component that is new here is, in addition to the administration of structured test items and the direct observation, the incidental observation, we also now recognize the importance of having the parent or caregiver actively participate in the evaluation process. So you'll see that there are a number of items that include what we refer to as a caregiver question. So if I do not observe the child demonstrate the behavior incidentally, if I'm not able to elicit the behavior by administering this structured test item, I can ask the caregiver question, and I could score that item based on the caregiver's response. So that is a component that is new. Now, why is it important to have the caregiver actively participate? Well, again, it's because, like I mentioned, young children do not necessarily respond on command. In fact, sometimes they actively refuse certain items that we present. So and then there are some behaviors that we evaluate that are more likely to be observed in the home environment. And for those behaviors, certainly being able to get the input from the parent or caregiver will be really helpful for this evaluation process. So one of the changes is these three interrelated elements where you might have some items where you might see you present the item using one of these methods, maybe two of these methods, or maybe using all three of these methods. And there are some items where you, in fact, use all three. An example I could think of maybe is on expressive communication, where we are instructed to listen to see if we hear the child making any consonant sounds. So does the child spontaneously produce consonant sounds? And if I do not note consonant sounds through incidental observation, I can have the caregiver attempt to elicit the sounds, and we provide some instructions as to how you could do that. Maybe you bang or rattle on the table, saying buh, 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 and see if the child is going to imitate your consonant production. And then if you don't observe the behavior, if the caregiver cannot elicit the behavior or you cannot elicit the behavior, maybe you ask the caregiver. And the caregiver question is really specific. For example, when Sandra makes sounds, do you hear her make sounds like da, ma, or ba often, not often, or not at all? And so the caregiver question, all of the items that include a caregiver question, you'll see the caregiver question both in the manual as well as on the record form. Another change is in terms of scoring. Now, those of you who are familiar with the Bayley-4 Screening Test or with the Bayley-3 or with the Bayley-3, you know that the scoring for the items on those 5 subtests, cognitive, receptive, and expressive communication, fine motor, and gross motor, the scoring effectively was dichotomous. So we would score the item 1 if the child demonstrated the behavior assessed by the item, if the behavior met the specified criteria. We would assign a score of 0 if the child's behavior did not meet the criteria specified for the item. And one of the things that we know about dichotomous scoring is that it is really good at differentiating the child who has mastered a behavior from the child who has yet to learn that behavior. So it's really good at differentiating mastery from not present, if you will, right? But it's not as good at picking up behaviors that are emerging, because whether or not the behavior or the skill is emerging or is not present, when we're using dichotomous scoring, in both of those situations, effectively the score for the item would be 0. So because of that, because we know that early development is dynamic, it's uneven, what we incorporated for the Bayley-4 screening test and for the Bayley-4 is polytomous scoring. So the items, each item will be scored either 2, 1, or 0. 2 when the child's behavior indicates mastery. 1 when the response or behavior indicates the skill or the behavior is emerging, and 0 when the child's response or behavior indicates the skill or behavior is not present. So that's going to be a major change which we believe really will allow us to capture that dynamic and uneven developmental trajectory which is common to young children. And the scoring of the caregiver questions, for example, when you call her name, does Sandra react to you often, not often, or not at all? That would be just maybe one of those caregiver questions that I kind of made up. But the scoring is going to mirror the scoring for the items. So if you're scoring an item based on the caregiver's response, your scores, your possible scores are 2 points, 1 point, or 0 points. Or so 2 points if the parent says, oh, she does that often, then you would assign a score of 2. If she says she does it not often, or in some of other questions the options are almost every time, some of the time or none of the time. The parent says not often, you assign 1 point. The parent says not at all, you assign 0 points. So you'll see that same 2, 1, and 0 reflected in those in the scoring for the caregiver questions. And just like we do for the Bayley-4 screening test, we'll have this screening test observation checklist that lists the items that often are scored through incidental observation. So you'll see the items for the cognitive subtest, receptive communication subtest, and also expressive communication, fine motor, and gross motor. And again, if you observe the behavior, it's sometimes useful to just go ahead and place a check mark over here that you observed it, so that when you get a minute, you can go back and make sure you note that on the record form. Some other minor changes to which I'd like to draw your attention is in terms of the order in which you present these subtests. The subtests are presented in this order in the record form: cognitive, receptive, and expressive communication, fine motor, and gross motor. But it's important for us to recognize that there is flexibility in terms of the order in which you present the subtest. If you are working with a child who is exceptionally shy, for example, it might make some sense for you to try to get the child warmed up by presenting some of the gross motor items at the front end. So there is some flexibility in terms of the order in which you present these subtests. Still, I think that the order in which they are presented in the record form really does make a lot of sense, because when you think about cognitive development, for example, the way that we are able to demonstrate that our thinking and reasoning abilities are developing as expected is because we use some kind of communication to respond to questions that you're asking, or maybe, for example, if you're asking me to imitate one of your behaviors using my fine motor skills, I'm able to use fine motor to demonstrate some cognitive ability. So I think often when you're presenting the items on the cognitive scale, you also get a lot of information about expressive communication. Children often use language spontaneously, which we can often use to score some of the items on expressive communication. Similarly for fine motor, children grasp things which may allow you to score some of the items on the fine motor scale. In terms of the order in which the items are presented, certainly these items are arranged in developmental sequence, in the order in which children typically will develop these skills. So for the most part, you want to present the items in the order in which they are presented on the record form. However, there is flexibility. And one of the ways that we try to formally introduce flexibility is through the concept of related items. And I'll say more about related items here in a minute. But related items really are items that might use the exact same manipulatives to present the items. And so once we have the manipulatives out, why not present all of the items that require us to use those manipulatives? So these related items, they might have different administration directions, and they'll be identified for you on the record form in this little box with an R. In related items, I think the best way sometimes is to give an example. So there are some items on the cognitive scale that use a ping board, and we expect the child to pick up shapes and put them inside the ping board. And then if you turn over that ping board, the other side is a blue board. So why not, when we have the ping board out to present the ping board item, why not at the same time or immediately following the presentation of the ping board item, go ahead and present those blue board items, especially if in terms of numbering, they come close to that ping board item. Now, it doesn't always make sense to present these related items one after the other because, of course, some of the items might be more appropriate for a child who's 3 years old. Some of the items that use the same object might be more appropriate for a child who's 3 months old, in which case the 3-month-old definitely will reach a ceiling before you get to those other items. So there is some clinical judgment that'll come into play to determine whether or not you administer all of those items in succession. But I think the concept of related items really is one that's going to be helpful for us as we think about maximizing the efficiency of the administration. We'll still have multiple trial and series. You think about multiple trial items and series items, some are both, right? So here I have 2 items, items 12 and 14, and they are part of a series, and they also have multiple trials. So here, for example, you have a child who you present this item using the instructions in the manual. The child gets trials 1, 2, and 3 right, gets trial 5 right over here, and trial 8 right, and then you use that performance to actually assign a score. And when we look at the criteria up here, you'll notice that if the child provides the correct response for 3 to 12 trials, you will assign a score of 2. And when you get down to item 14, you'll use the same information up here to assign a score for item 14. In this case, the child should get at least 6 correct in order to earn a score of 2. In fact, the child got 5 correct, so we would assign a score of 1. So series items, just like on Bayley-4 Screening Test, you administer the first item that you encounter in the series, and then you use the child's performance on that item to score the other items that you meet along the way. The calculation of the test age is the same as it was before. Subtract the date of birth from the date of testing and make sure that you express the child's age in months and days. So you'll be converting age in years and months and days to months and days. What is a little different is the calculation of the adjusted test age. So the adjusted test age on Bayley-4 is calculating by identifying the child's expected date of birth and then subtracting the expected date of birth from the test date. But in terms of adjusting for prematurity, we still adjust up to 24 months of chronological age, and prematurity is effectively defined as 36 weeks or less in terms of gestation. But the age or the adjusted age will be used to identify the start point, just like we do on Bayley-4 Screening Test. The reverse rule and the discontinue rule conceptually are the same as they are on the Bayley-4 Screening Test. So the discontinue rule, stop administration if there is a score of 0 for 4 consecutive items. So that'll be your ceiling. The reverse rule is the same conceptually. There is a slight variation compared to the Bayley-4 Screening Test, of course, because of that polytomous scoring now. So instead of saying if the child obtains a score of 0 on the first item, we say if the child obtains an imperfect score. As we know, a perfect score would be 2. So if the child obtains a score of 1 or 0 on the first item, you find the previous age start point and administer those items in a forward direction. Okay, let's see if I forgot something. Okay, looks like I skipped something here. In terms of the test scores, this assessment will identify a cut score for each of the 5 subtests, and the cut scores are used to determine whether the child shows high risk, borderline risk, or low risk for developmental delay. So the way that that'll look on the front page of your record form, certainly I already showed you the calculation of the child's age, and then you'll use the child's age and go to a table in the manual. Up here, it might be hard to see, tables A1 through A5, cognitive and A1, receptive communication and A2, and so on. And you'll identify the raw scores for each of your 5 subtests, and then you'll find the column that includes that cut score. So let's say I'm working with a child who's 13 months and 2 days, whose cognitive raw score is 23. I'd go to the table, make sure I find the child's age, the row that includes the child's age in months, and then I'm going to find the raw score of 23, which falls in the borderline risk category. And so I'll do that for all of the remaining subtests, receptive, expressive, fine motor, and gross motor. And for this child, you notice that cognitive falls in the borderline risk range, the language in the high risk range, and then the motor in the low risk range. So that's pretty much the information that you'll generate using the cut score information in the manual. And this is consistent with the way that we used the Bayley-4 screening test as well. Okay. So I want to spend a few minutes talking about the technical properties, because I think developmental screening certainly is important when we think about early identification of infants and toddlers at risk. We understand the importance of providing early intervention services as early as we know that a child needs early intervention services. And so it's important for us to select a tool that will provide us with the information that we need to be able to identify those infants and toddlers who need to be referred on for a comprehensive diagnostic evaluation. So I think when we look at the technical properties, certainly you want to think about the characteristics of the normative sample. Let me see where I am here. The characteristics of the normative sample. And the normative sample for the Bayley-4 screening test included, if we add up all of these here, included 1,700 children who were divided into these 10 age groups that you see here. And certainly there were some stratification variables that we used. The sample was stratified by age, as I note here, also stratified by gender, race, ethnicity, by parent education level. And whenever we develop a test and we find our standardization sample, we use data from the U.S. Census Bureau to actually provide the basis for stratification. And we used the information from the 2017 data from the U.S. Census. The sample also was matched for region. We always want to make sure that we have children from the 4 major geographic regions specified by the U.S. Census reports, but region was not included as a stratification variable because we found over the years that region accounts for very little of the score variance. So all of the items for the Bayley-4 screening test, as I mentioned before, were derived from the full Bayley-4 item set. So we considered certainly content characteristics, psychometric characteristics, clinical sensitivity was an important consideration in identifying the items that were included on the Bayley-4 screening test. And once we had our data, one of the things that was important was for us to derive those cut scores. I showed you table A1 that included the cut scores for high risk, borderline risk, and low risk, those 3 categories. So we started out by identifying 2 major cut points for each of the for each of the age groups, and that allowed us to divide the scores into these 3 age bands: the high risk, the borderline risk, and the low risk categories. And the cut scores were identified by examining the cumulative frequency distribution for each of the 10 age groups that we just saw. Now, the cut scores were selected to represent roughly the second percentile. If you look down here at the bottom, you'll see the target percentile range to represent roughly the second percentile for the high risk category and the 25th percentile for the borderline risk category. So when you think about a percentile of 2, that would indicate that 2% of the children in a given age band would have scores that fall at or below the cut score. And if we think about what that means, a percentile range of 2, a percentile rank of 2, we know that that kind of falls into that standard score that we would use as the cutoff for developmental delay, a standard score of 70 or a scaled score of 4. Now, the other thing that was important as we were developing this tool is to think about the reliability of the tool. And when we look at the reliability of the Bayley-4 screening test, you'll notice here that the average reliability, average internal consistency reliability for the Bayley-4 screening test, you'll notice that the overall, and we present in the manual also by age group, you could see for each of those age ranges. I pulled out the information for the overall sample, and you'll notice that the overall average reliability coefficients range from 0.86 for fine motor to 0.92 for expressive communication. But I want to spend just a few minutes talking about validity, because I think especially when we're thinking about a screening test, it's important for us to understand if we're going to be using the tool, whether or not the results will be either valid or invalid for making the interpretations that we desire to make. And certainly based on the Bayley-4 screening, the interpretation that we want to be able to make is whether or not we need to refer for a diagnostic evaluation because this child is at high risk for a developmental delay. So in the manual for the Bayley-4 screening test, you will find validity evidence based on the content of the test. You'll find evidence based on response processes. You'll find evidence based on the relationship between the Bayley-4 screening test and other variables. And you'll find evidence based on special group studies. I want to spend a few minutes talking about some of these special group studies because we want to make sure that this is going to be a tool that will allow us to identify individuals or young children who might be at high risk for developmental delay, maybe at high risk because they were born prematurely, or maybe because of a motor impairment, or because of any of these clinical conditions that we have listed here. So several studies in the manual will provide evidence supporting the validity of the Bayley-4 screening test for these special groups or these clinical groups. I pulled out the information for one of those clinical groups, the developmental delay special group. The Bayley-4 screening test was administered to 57 children identified with developmental delay. Now, one of the things that we know about developmental delay is that the criteria that are used to identify a child with a developmental delay really are determined state by state. So looking at the different criteria used by the states, these 57 children were identified with developmental delay based on the criteria of the state in which they resided. Now, the children in the developmental delay sample, we would expect theoretically that they would exhibit global developmental delays across these subtests: cognitive, receptive, and expressive communication, fine motor, and gross motor. And what we found effectively when we look at the mean scores for your special group, the DD mean, compared to the matched control mean, the mean for a matched control group matched on different demographic characteristics such as age and gender and so on, you find that for all of these subtests, the score for the mean score for the matched control group was higher than the mean score for the developmental delay special group. And we note the difference between the two right here. And these differences are significant. They are true differences, and you notice over here in the standard difference column, the effect sizes are moderate. So just as we would have predicted, the developmental delay special group scored lower on these 5 subtests than a matched control group. In terms of the percent identified as high risk or borderline risk, again, if we look at the percent in the high risk category, you'll notice that for your developmental delay group for cognitive, for example, 21% were identified as high risk versus 7% in that matched control group. For receptive communication, approximately 25% fell in that high-risk category compared to about 2% in the matched control group. So again, just as you would have predicted, you see that there are more children in the developmental delay group who were identified as high risk, so their scores actually predicted that they would be at risk for a developmental delay, and we know in fact that they were already diagnosed with a developmental delay compared to children who did not have such a diagnosis. The other thing that I think is important to consider when you're considering a screening test is the classification accuracy when you think about the Bayley-4 screening test compared to the Bayley-4. Because effectively what the expectation would be is we administer the screening test to a large number of young children. We identify the children who are at risk for a developmental delay, and then we follow up that high-risk classification with the administration of the Bayley-4. And what we would like to see is that there is some relationship. What we'd like to see is that the high-risk classification on the Bayley-4 screening test actually predicted effectively a classification of developmental delay based on performance on the Bayley. So when we look at this table right here, this presents the classification base rates of the Bayley-4 screening test with the Bayley-4. So as I mentioned, the Bayley-4 screening test will provide a risk category, whereas the Bayley-4 will provide us with a scale score. I mentioned that in terms of high risk, the scale score associated with a high-risk classification is a scale score of 1 to 4. Percentile rank of 2 would be a scale score of 4, whereas 5 to 7 associated with borderline risk, and then 8 to 19 associated with low risk. So what we're looking for here is to see whether or not there is going to be a match between the risk category classification from the Bayley-4 screening test and then the actual classification or the scaled score on the Bayley-4. Let me see if I can get rid of some of this here. So when we look, for example, here at the high risk, which would correspond to a scale score of 1 to 4, you notice for cognitive, receptive, expressive, fine motor, and gross motor, you'll notice that the prediction rates, about 54% of individuals who were identified as high risk on the Bayley-4 screening test were also identified as effectively at risk, looking at their scale score on the Bayley-4. And you notice that these percentages range from 54 for cognitive to 67.4 for gross motor. And you could take a look similarly at the borderline range, which would be the ones here in the middle, and then at the low risk range, which would be the ones out here to the right. And you'll notice for the low risk, you notice that those percentages are in the 80s. So young children who were identified as low risk ended up earning scale scores between 8 and 19 on the Bayley-4. The other thing that's really important when we think about a screening test is to think about the utility of the screening test. And one of the means for evaluating the utility of a screening test is to analyze the ability of the test to accurately identify the children who will need further assessment. So there are several different statistics that are used to describe the utility of a screening test. So I want to talk about 4 of those statistics here, starting with sensitivity and specificity. So sensitivity, especially when we think about a screening test, is really important because it really tells us the probability that a child with a developmental delay will actually test positive for a developmental delay, right? And similarly, sensitivity is often referred to as the true positive rate. So the child has a developmental delay, and the Bayley-4 screening test predicts that the child will have a developmental delay when we, in fact, administer the Bayley-4. Specificity, in contrast, is the probability that someone without a developmental delay will test negative for it, right? So you're thinking about the true negative rate. Now, one of the things that is really important in addition to sensitivity and specificity is specific diagnostic base rates. When you're thinking about classification accuracy, sensitivity and specificity are really important, but in addition, using diagnostic base rates or the prevalence of the condition in the population really is important as well. And those have to do with predictive power, whether positive predictive power or negative predictive power. So just to use this little graphic here to illustrate the possible outcomes of classification if we're using a test like the Bayley-4 screening test. So let's use the D here to represent someone who truly has the disorder, who truly has a developmental delay, and then ND to represent someone who truly does not have a developmental delay. So the test outcomes, when we think about the Bayley-3 screening test, are either positive for prediction of a delay or negative for prediction of a delay or disorder. I'm referring to delay because that's what the screening test measures, but more generally, you think about a disorder. So when you think about predictive power, you think about it either in terms of positive predictive power or negative predictive power. And the positive predictive power is the likelihood that the person with a positive test result, see if I can mark that, with a positive test result will actually have the disorder. Like I said for sensitivity, a true positive. Similarly, when you think about negative predictive power, that is the likelihood that someone with a negative test result will not have the disorder. So what is the likelihood that someone with a positive test result actually has the disorder? And it would be nice if that likelihood of that prediction was completely accurate, which would be a coefficient of 1. And similarly for negative predictive power, if you have true positive, 100% accuracy in terms of your prediction, the coefficient would be 1. In fact, I think in most cases the coefficients are lower than 1. So you have maybe some that are true positive. You also have some that are false positives. And in addition to your true negative, you have some that are false negatives, right? So you think about maybe lowering the number of false positives and lowering the number of false negatives. So on the Bayley, we report on the Bayley-4 Screening Test, we report classification accuracy for certain special groups, including autism spectrum disorder, developmental delay, certainly Down syndrome, language delay, motor impairment. And I pulled out some of the information to show in terms of your sensitivity, specificity, your predictive power, both positive and negative. And like I mentioned, predictive power really relates to the prevalence of a disorder in the population, right? So what is the base rate? So we report different base rates in the manual, and do take a look at those. I pulled out the one for screening, which is the prevalence rate of 10%. But one of the things I want to show you here, I pulled out for language delay and motor impairment, and I'll skip through that motor impairment one here in a second. But I want to show you how the data are presented for the Bayley-4 Screening Test. When you think about young children with a language delay, certainly we want to make sure that we have information about language, so receptive communication and expressive communication. Also, we understand the interrelatedness of cognitive and communication, and so we present the information for cognitive as well. So when you look at the cognitive subtest, the results up here for the high-risk category indicate a sensitivity of 0.04 and a specificity of 1.0. When we look at predictive power, notice your positive predictive power for a base rate of 10% is 1, and negative predictive power is 0.0. When we combine the high risk and the borderline risk categories, notice that sensitivity increases to 0.52 and specificity is 0.84. And notice your negative predictive power over here of 0.94. So you want to take a look at these clinical validity statistics when you think about the groups of the special groups with which you work, so that you could look at the sensitivity, specificity, positive and negative predictive power of this tool for predicting a language delay, predicting motor impairment, predicting developmental delay. You can take a look at the information in your handout for the motor impairment group, and like I mentioned in the manual, we have additional information for those other groups as well. So I think as we get to the end here, when we compare the Bayley-4 Screening Test and the Bayley-4, I mentioned some things about the scales. The Bayley-4 has 5 scales: cognitive, language, motor, social, emotional, and adaptive behavior. The Bayley-4 Screening Test includes 3 scales and 5 subtests. So no social, emotional, no adaptive behavior. I showed you information on the number of items, certainly fewer items on the Bayley-4 Screening Test compared to the Bayley-4, 129 compared to 264. Administration and scoring of the Bayley-4 Screening Test using the materials that are part of the kit. For your Bayley-4, there is the option of the on-screen administration and then the Q Global scoring. The scores that you'll be able to derive, the cut scores for the Bayley-4 Screening Test, and then for the Bayley-4, scaled scores, standard scores, percentile ranks, age equivalents, and so on. And the interpretation, of course, is different, because the interpretation of the Bayley-4 Screening Test is to determine risk for developmental delay. The interpretation of the information from the Bayley-4 is to establish a diagnostic classification, in most cases developmental delay. We'd like to tell you now about the Bayley-4 Screening Test Kit and some of the options available on our website.
Thanks, Gloria. Hi, everybody. This is Shelley. I'm just going to jump in for this part. I'm Shelley Hughes. I'm the product manager for the Bayley scales. So a couple of things just to let you know that are happening with the screening test. As Gloria said, we are set to publish in the middle of November. It was originally December, but we've been able to bring it forward slightly, so it will ship before the holidays. We do have a 10% discount, which runs through to the end of the year. This is on the screening test kit only, so it's not on the Bayley-4. We did have a pre-publication discount on the Bayley-4, which ended on September 30th. So this is for the screening test. But one thing to note, this isn't on the website yet, but it will be on the website very soon. I was hoping to get it up before this webinar today, but it's not quite up there, is that there is a combination kit we've set up with the full Bayley and the Bayley-4 screening test. And that too is eligible for the 10% discount through to the end of the year. So, so when you look at that when it's available, it does mean that you're virtually getting the screening test at sort of $21, I think, more than you would for buying the full kit on its own. So look out for that on the website because that will be going live very soon. And then just another thing I just wanted to highlight, because this is something that a lot of people ask, and that's just if you have a Bayley-3 screening test already, and I know there's a lot of people from the poll we did at the beginning of the presentation, so a lot of you aren't using the screening test, but for those of you who are, we do get asked if you can update or use the existing manipulatives that you have with your current Bayley-3 screening test. On the screen right now is a list of all the additional manipulatives that we have in the Bayley-4, and actually it costs the same to buy these separately as it does to buy a whole new set of manipulatives for the screening test. The pre-publication price on the full set of manipulatives is $148.50, and item by item it works out at $148. And with the $148.50 you get the entire set of manipulatives, not just the new ones as well. So I just wanted to highlight that. We have 3 minutes left, and we've had a couple of questions come in that I just thought I didn't answer in the chat, but I thought I'd just answer here now whilst everybody's listening in. And the first one is a question about when working in settings where the mother won't know the expected birth date, are there any other ways to identify a premature birth? Now, I don't have a definitive answer on this, and I'll just mention a couple of things first, and then I'll see if Gloria has anything to add. But we have had this on a presentation, I think it was the last one we did with the author, and he gave some good guidance and some good advice on this. I'd have to find that recording, but we do have those recordings on the website. We ran a series of recordings through the summer, and I'm sure that was a question that came up previously, and I don't know the answer, a definitive answer, but I'm sure there's some guidance out there. I don't know, Gloria, if you have anything to add on that or any experience on that.
Oh, thank you, Shelley. Yeah. I think often that information is included in medical records, so I would refer often to medical records to find that kind of information if the parents really aren't aware of what that might be. That might be one source.
Excellent. Thanks, Gloria. Yeah, that's a good point. Okay, another question that came up is, could we consider those at low risk, with a cut score at low risk, as being average or at no risk? Now, this question was asked before you went into the risk categories, and perhaps it's already been asked, but I'll just sort of reiterate it now in case you have anything more to add on that one, Gloria.
Okay, yes, thank you. So one of the things that I tend to like to look at when I look at these risk categories is really, okay, let me see if I can get back to that slide here. At these risk categories is I look at the actual cutoff scores, right? So you'll notice, for example, for this child who's 13 months, you notice that her score is 23, falls in the borderline risk category. But let's say that this child's score was up here at let's say the raw score was 26, which would place the child in the low risk category. But you realize that the range of the raw scores for low risk is 26 to 60, when a child's score falls right at the beginning of the range of scores for that category, I really like to think about the child straddling the borderline and the low-risk categories. The other thing that I like to think about is these percentile ranks down here at the bottom. I know that a percentile rank of 25 kind of equates approximately to a standard score of 90. So I like to think, okay, so does that mean that the child's development is average? Does that mean that we shouldn't be concerned about the child? That depends. It really depends on a lot of factors. And if you think that a score of, let's say, a percentile rank of 25 would be a child with whom we'd like to intervene as early as possible to make sure that the child doesn't fall further and further behind, that's certainly something that I would take into account. But look at the actual raw score. Look at where that raw score falls in terms of the range of scores for each of these categories, and then also think about the percentile range that's associated with each of these three categories. I hope that makes sense.
Wonderful. Thank you, Gloria. And on that note, I think we've just run over by 1 minute, so it's perfect timing. So thank you, Gloria, for a really, really engaging presentation. And thank you, everybody, for listening. I don't know if you've got any last words, Gloria?
No, thanks, everybody. And if you have any other questions, our email addresses are here.
Wonderful. Thank you.